Okay, so yeah, so now you are ready.
Yes.
Any guess thing? What is the next scenario going to come up? Any prediction? You thought of something?
Increased drain from the
Increased
The
drain from
apparent
the
has not been
yeah,
restarted.
Okay, let's see what comes up with you. Okay, fine. Anyway, so this patient, obese female, was cannulated somewhere else, transferred. During transport, there was some minor issues that was been corrected, but then gone through a lot of things in between. It was doing well, extubated, mobilized, right heart failure, so re-intubation. After re-intubation, she never uh, let us again extubate her. So volumes has gone down, and she's just getting 90, 100 ml of tidal volumes. Uh, she developed pump failure, and that time it took longer time to change the pump, so cardiac massage was given. ACT target increased because there was a clot in the pump, and that's the reason patient developed an ICD with a mediastinal shift. Don't need to put in ICD, and then the ICD is draining well. Yesterday's total drain was around 450 ml with a blood stinged fluid. Okay. Immediately after putting an ICD, patient stabilizes, saturation has come up to 90. These are the parameters what you can see right now on the board. Rest of the things remain stable. So ICD column is moving well, and things are fine. So it's now over to you. It's your patient now, and you have to manage. Because there was a bleed, we have stopped heparin for almost 6 hours and restarted heparin with an ACT target of around 140 to 160. That was the target decided. So it's over to you now.
How much is today's hemoglobin, sir?
Hemoglobin is 9.8.
Blood gas, sir?
ABG.
Blood gas?
Blood gas.
Morning by ABG?
Morning blood.
Okay. pH is around 7.38. PO2 is around 58. PCO2 is around 36, and bicarb is around 22.
how is chest X-ray today's?
Chest X-ray I'll show you, but that was immediately after putting an ICD. That was the last X-ray which was done.
We'll examine the drainage cannula site if there's any
Yeah, you
seepage or
can.
anything.
Do whatever. It's your
We can
patient now.
open an head to toe examination also. Yeah.
Descend the roads. Column
Yes,
movement.
right.
The color difference is
Yeah,
obvious.
yeah,
and
yeah.
then
The
display
column
the
is
column
moving.
is moving.
Urine output, sir?
Yes.
Yeah. Urine output is okay, around 75 ml per hour.
The drains are also not too much. So
Yeah.
okay. Hemoglobin.
Sweep gas and every connections are okay here.
Everything
20
looks okay.
settings.
Peak
Oh,
pressure is
20
fine.
or
27.
How much is the sweep gas now, sir?
It was 4 liter they have made. It is 4 liter.
4
okay.
So
As
is
of
the since he's like almost she's pretty stable, so we've not assessed her like I mean GCS and like talked to her that way. So and any like physiotherapy also we've not initiated. So that part is still
Current ACT.
not looked at. Now she's stable. That we might as well.
Yeah, you do what? Well, if you feel, you can ask for physiotherapy and everything.
He's still
We
sedated,
can- yeah,
sedated and
sedated.
paralyzed. Still,
Yes,
sir?
patient is sedated
Yeah.
and paralyzed. So far,
Paralyzed.
we have not assessed the neurological status also.
Saturation is dropping and the tachycardia.
Yeah.
Yeah.
Air
So
col-
let's.
air column movement has stopped.
Already on 100%.
Yes.
Air column
Air column movement has stopped.
Air
It has
column is
stopped.
Yeah.
What is the latest ACT?
Current
Late-
ACT
Current age.
ACT 145.
45.
The color is
Moving again.
Yeah.
Yeah.
But
We
still the
can.
saturation
It's
is going
100%
down.
FiO2. So we
100%
can't. Can we
FiO2.
increase the?
ECMO FiO2.
57,
Yeah, it's
ECMO
already 100.
FiO2.
It's already 100.
80. It's 100%
Yeah.
only. FiO2 is 100%.
Mhm.
HB,
Yeah, you
sir?
can see it.
HB?
P2
pressures
has
are-
increased. P2 has
Ah.
increased.
P2 has increased.
Oh,
It was
P2.
133.
Yeah.
P2 is high.
So we have to check the oxygenator.
Oxygenator. Torch.
Torch.
For any clotting.
Torch, please.
Increase the flow.
P2 increase, check it then. P3 is same, but
There are
only
few
P2.
fibrin clots on the venous and return side, arterial side.
And the color.
Oh,
Delta P is 36.
The color change is there.
Color change is still
Color
there,
change
yes,
still there.
yes.
74.
But the P2 is high. The delta pressure is normal.
So the P2 pressure is still,
High P2 is
but delta
increased
pressure is still
drastically.
same actually.
Delta P is
so
Before
where
the
is the P2?
oxygenator?
We'll have to discuss that.
How much is delta pressure?
36.
36.
36.
Is it?
But it is
the
the
change.
value.
Change.
221
It's
minus.
actually
How much is P2 and P3?
Yes,
Ah,
sir.
it's quite
It's
different.
100 strong.
100.
Difference.
The person is
Alternate.
giving you wrong calculation,
Wrong
isn't it?
calculation.
Yeah.
Yeah, wrong
Yeah.
values.
So, but how much is the actual delta pressure?
It's around 9.
100.
100.
100.
It depends upon the oxygenator.
80.
So, how much is delta
90.
pressure here?
Here it's
10
36, but it's
109.
wrong.
It's wrong.
108.
90 around.
Around 90.
Around 90.
90.
Sensor.
Okay.
So the pressure is increased.
So
So the
change the
oxygenator,
oxygen.
Could it be membrane
oxygenator
edema?
failure,
No, membrane edema. After
membrane edema, PCO2 must be high.
Yes.
But
Sir,
the
ABG,
Patient ABG?
ABG.
Pre and post.
Pre
ABG.
and
Pre and post ABG. Okay. Pre ABG is pH is around 7.28, PO2 is around 438, PCO2 is around 48, and bicarb is 20. Post oxidant ABG pH is around 7.32, PO2 is around 150, PCO2 is around 46, and bicarb is 20.
So we can increase the sweep gas.
one
4 times
uh,
increase of
30,
sleep gas for
525,
20 seconds.
25,
we'll have to hurry up the
1200.
saturation.
Sweep gas.
What is the
So
sweep
sweep we can
Pension.
increase.
We
By-
can.
We'll
We'll try.
increase by 0.5.
It's not increased.
Is it working or
It's
not? That is
100%.
Oxygenator.
They will
yesterday. Yesterday
much
there
was
was a
ECMO
blender
effort was
mistake.
100.
Supply
was-
wasn't
Method is-
good
Yeah.
from the
HME
blender.
change.
Okay.
Not that.
Then there was a
No, no.
yesterday the HME wasn't working.
No,
The
No,
sweep-
the difference
considering
between
the sweep
was,
gas,
blender
CO2s are
was
around the normal
dysfunctional.
range.
Yeah, it is on the normal. So
Normal.
saturation
Saturation
is
is
low.
reduced.
So
oxygenation part.
Oxygenator
no
because
function.
P2 is
Yeah.
P2 is what
increased.
is increased. So
So there is some resistance. I mean,
Resistance.
oxygenator
and the
resistance.
oxygenator.
The oxygenator is 22 days old, right?
We have to
So
get
I'll-
ready
Change the
with
oxygenator.
emergency talks
Yeah.
here.
Ah.
We'll
So
get
shall-
ready.
ammo and
We'll
As-
get ready with
Emergency
yeah.
trucks.
Maybe we'll have
We'll
to
change
change
the
the
oxygenator.
So we
oxygenator
have
then.
decided about the change in
Change the
oxygenator. So
oxygenator.
we will divide
Ah.
among ourselves into two teams.
Okay, give them oxygenator to change.
One team will take care of the
Okay.
patient. The other team will take care of the oxygenator
oxygenator.
change.
Okay. So,
So
we are
we'll have
going
the
ahead with
ambu,
ambu.
ambu. We'll have ambu
Ready.
or yeah, and
Yeah.
then emergency drugs.
If in case CPR is required.
Ah,
ambu.
no,
Tell me whatever you want to do. Okay, we'll do that.
We need a new
clamps.
oxygenator.
Yes.
Clamps.
Somebody will go
Have
and
to
change the
prime
oxygenator there.
oxygenator once.
Achha,
flush.
Okay.
100%.
Prime
You
the-
be on this side.
Ah, sure.
We'll
I'll take
bring
it.
the
100%
oxygenator.
done.
You.
Ah.
You increase the
Here only.
100%
Here only.
oxygen.
Yeah,
Okay.
oxygen 100%.
Any
Prime
other
the
change?
artery.
Any other change on
Prime
ventilator?
the.
Ah.
I'll
Maybe we can increase the time
It's
to
already
volume.
primed.
How
right?
much?
akkade cheyali.
It's a pressure
You have
control
to
mode
do it
now.
there only.
This
You
is
can
the
take it.
arterial
Inspiratory
With this
pressure.
can
Yeah.
Peak
Avunaya?
inspiratory pressure.
How much you want to increase?
17.
It's already
Maybe
primed.
20.
Some more.
22.
No, not now. Not
It's
now.
27
After the
now.
preparation, we'll do. It's elective,
plate two.
elective, right?
Peak
Yes.
pressure.
We can do it slowly. It's not an emergency.
PC above
No,
is
there's an
17.
emergency.
Maybe
27 right now.
27.
Yeah.
Yeah.
Let's see how much it goes to, sir.
So how much you want?
Connectors. Do you have
One
connectors?
second.
You want
should be-
22. Peak
Yes.
Connector.
PC above PEEP.
Do you
PC
have
above
connectors
PEEP.
there?
Yes. We'll bring the oxygenator. You change it
Take the
fast.
plate. You make a nick in the
Do you
nick
have-
in
you
the
have
previous
connectors, right?
oxygenator.
Yes, we have
Rate
connectors.
also we
You
can
connect.
increase, sir.
How much?
Rate by
That is the
Hey, let me know when
We'll
they
do here only.
We'll do here only.
when they change the clamp the oxygenator. Huh?
Connect.
This is pre. This is post.
Do it.
Anything else you want to change in ventilator?
So
The
double,
rate.
One
Make
second.
a
double
nick.
clamp.
Done.
first,
30 you said, isn't it?
Rate.
I've done it.
Yeah.
Ah, First arterial, followed by venous.
100%.
FRT, sir.
Dec-
Yeah.
no
First
need to
artery.
decrease the RPM.
First
And
artery.
for-
Clamp the
First
artery.
clamp the
Clamp
artery.
the artery. That's
Both
Anything
the
else you
clamps
want?
can be done.
We might need
So I will connect. I will connect the pre. You connect the
emergency
post.
drugs as in
Emergency.
the bolus dose
First
of
do the first
adrenaline
do-
and
first do
noradrenaline
artery.
Since this has a connector, you
Then
can
double
cut
clamp,
it
yeah.
here.
and ambu,
Distance, yeah.
if
You
in
don't,
case.
you cut it here.
Clamp.
Circuit
connector,
clamp.
You have the
yeah.
We have
connectors,
the
right?
connector.
Lily, ikkada.
Connect.
One here, one
Hemodynamic
here.
system. Okay, saturation is
We have
60.
the connectors, right?
Hemodynamics is going
Ah.
down.
That's
Flows
fine.
are in
Yeah.
The
I
sat
know.
is
Don't
falling
tell
down.
Malli.
We might as well disconnect and connect
Yeah,
to
yeah.
ambu
Ambu.
and
Come
then
on,
fast.
come on, we want
Advance,
ambu.
yeah, clamp, clamp, clamp.
Excuse me, we want
We
an
want
ambu.
ambu.
An
The
ambu.
We
sats
have
are
already
falling
connected,
down.
right?
Yes.
Connect, na.
Almost
Clamp, clamp, cut.
very
cut.
alert.
Yeah,
Scissors.
Here.
There's no scissors.
connect to
Where's
oxygen.
the scissors? Where's the scissors?
Oxygen.
Its saturation is
Get
going
ready
down.
with
Yes.
the
Brady, the patient
yeah.
is
There
going
will be
to Brady.
some
That's not the
acidosis,
way.
so get ready with some bicarbonate.
Yeah.
Are you
Bicarbonate.
ready?
Yeah, yeah, we're doing.
Okay. So we're having some bradycardia,
Wait.
57,
NS.
heart rate, SATs of 18.
wait.
NS, NS.
Will
Yeah, nice.
will compress.
You have one more?
Or
Yeah.
it's okay, still
Should
waiting.
we
Start
see?
one
Yeah.
adrenaline.
Yeah.
Take.
We will
Adri,
start
we don't
with
have
One more
CPR.
NS.
Yeah.
We need
We'll
one
just
more.
wait.
Now
We need one more. NS.
The heart rate is done.
No,
we'll give some
Okay.
CPR.
Connect
Yeah.
first
Yeah,
one
me-
people
meanwhile,
connect.
we'll start inotropes. We'll
Yeah.
start CPR.
escalate on the inotrope, sir. Start inotrope.
Okay.
Or adrenaline.
You want not adrenaline?
No,
I
right
will
now
go
we have started.
Yeah, we
Adrenaline,
want
adrenaline.
adrenaline.
Yes.
Adrenaline,
Here,
sir.
here, first
Connect,
fill.
connect.
And bicarbonate, 50 milliequivalents.
Yeah.
We have
Slowly.
started the CPR, guys. So
It's done. It's done.
We have maintained the diastolic pressure to 21 at least. Someone ready? Get ready for replacement.
yeah.
Yeah. I'm
దూరం
ready.
పెట్టుకోవాలి yeah done
Done.
We have to see.
Open the
increase the flow
arterial clamp first,
1500.
followed by venous. Yeah.
yeah
Yeah, RPM is full. Okay.
There is air in the.
1500 followed by
Okay, okay.
Take out
No,
the
Okay, I'm
Go
going to
back up.
change.
Yes.
Compress, continue compression.
Do you want me to give adrenaline?
Yes, one more adrenaline.
One more.
yeah
Ready?
Okay.
Flow back up.
flow is
Okay, flow back up, sir.
Close back.
Flow. How
Will
much
go.
is the flow now? 3 liters.
10 liters.
3.2.
It's hardly 0.5. Point.
liters.
Yeah,
It's
now
coming
it is
back. It's
coming
coming
up.
yeah
back.
4 liters the flow is full
This is because of the. Yeah.
Okay.
Cross
So it's
cut
back. We disconnect. And
No.
You can probably continue in the ammo.
No, no.
Why?
that's
Okay.
So
back up.
तो उसको
Saturation
clamp
is
करके निकालना पड़ेगा.
back on ventilator. Rest vent settings, sir.
अच्छा, okay.
We can come back to rest vent settings, sir. Yes, sir.
clamping దగ్గర లేట్ అయింది clamping late అయింది
Reduce the FiO2.
Color is okay.
కొంచెం air in.
Yeah, color is okay.
Flows maintaining, right?
yes
B2 has not come down.
पंप में क्या ऑक्सीजन में था
ఏమైంది
What happened?
What? Pump nahi hai.
What happened?
ఎయిర్
Yeah. But the pressures are still high.
Fine.
Yeah, the
I
pressure
think we'll
is
end your scenarios here.
Yes.
Okay. So, what was the thing you thought that case an oxygenator failure in change oxygenator?
P2.
P2 was
P2 was
P2
higher
pressure.
It was very
The
high.
delta pressure.
delta
was-
pressure.
Delta was
Delta
good,
pressure.
gone up. Okay. And
And desaturation.
desaturation.
not up
Yeah.
to
Post oxygenator PO2 was
PO2
150 only.
Um,
Okay.
And
then-
we ruled out other causes of hypoxia, sir. We have seen for technical and mechanical complications, ICD. We have seen the chest X-ray,
HB.
which was the same. Hemodynamics.
Torch test.
Yes, sir. We.
Yeah, that was showing clots.
Clots. Sir.
Okay, so
Fibrosis.
that was a diagnostic that you need to change oxygenator. Okay. Now coming to the patient management team. Okay. One thing you did good is you divided yourself in 2 teams, and one team was stuck to the patient. They didn't jump there to see what they are doing. So that was good. Okay. What was your observation? How did you manage your patient?
So So we had to go up on the vent setting so that we could like maintain the saturation of the patient while they were changing the oxygenator. So we tried to increase the minute ventilation by going up on the inspiratory pressure and the respiratory rate and the FiO to 100%.
But did that help?
Not really.
Not really,
You
because the
pressed
lungs
your
were
tridolum,
already
which was 90, has gone up to 130 only.
Mm.
Anything else you could have done?
Peep maybe.
PEEP
Just. Or
shifted the
flows.
patient on.
Why didn't you take the patient on Ambu?
Manual
Yeah,
ventilation.
We
Manual
took it
ventilation.
but after some
Yeah.
time, yeah.
During CPR, we shifted to.
Yeah, could have been done earlier.
Earlier,
If
yeah,
the
yeah,
saturation
yeah.
is not
Yeah.
picking up, you could have
We
taken
could
on
have,
the
we could
manual
have.
ventilation because there you can force some more tidal volume
More some.
that could have participated for gas exchange.
Have you increased sweep gas?
We
Yes.
did.
Yes, sir.
We
Yes,
did,
have
we did.
increased.
We
did.
increased,
Yeah,
we
we
did in
increased.
Okay.
We initially tried with sweep,
Sweep
gas, then
gas.
it did not improve.
Yeah.
So then we
Okay.
switched to.
No, I'm talking about sweep gas when you were changing the oxygenator.
Okay.
No, no, no.
So
I don't know, oxygenator was failing, so how much that would have helped, but that could have easily been increased
Okay.
to 1.5 times or so.
Yes.
Okay, fine. Coming to, I think rest everything you have done well. Cardiac massage and I suppose you give bicarb also, isn't it?
Yes, sir, we did.
And you get adrenaline also.
We were not very, we had a bit of fear about that.
Convinced,
We
but
didn't
So,
really
but
That's, I think it's
Arrest.
a
Yeah.
reflex
Arrest.
section.
reflex.
Sir,
We were,
but,
but we still contemplated, so. but we-
Reflex section.
Yeah, sir,
I would have tried to avoid it.
Yes, sir.
It can definitely, well, when you see that, you will realize it.
Yes,
So I have seen that. So that's the reason I'm very skeptical of using atropine and adrenaline in
Yes.
at least VV ECMO. I'm very skeptical.
Sir, but soda bicarb causes intracellular acidosis.
But it was.
Yeah.
Yeah, see,
We are bothered for.
what you are just doing it for transient time. That's it. You are just buying a transient time. That's it. Nothing else than that. Okay. Yeah. About patient management, ECMO management team. What did you find and how did you go? Yeah, ideal life is less than 5 minutes. The moment you reconnect oxygenator, your CO2 will get to wash out within 30 seconds. Okay. So your pH will become normal. So your adrenaline will definitely act. And once adrenaline acts, it causes tachycardia. And once there is a tachycardia, you get a recirculation. I'm not worried about the adrenaline effect, tachyarrhythmias and that. My worry is recirculation. That's why I say in VV ECMO. So if the heart rate goes to 170, 180, 190, we'll see recirculation. So patient was already hypoxic for some time. Again the patient goes into recirculation, hypoxia will again come back. So that was a concern. That's why that's the reason I usually avoid adrenaline as far as possible. Okay, fine. So what about patient ECMO management team? What did you find? What are the difficulties you faced? You took, I think, 1 minute 54 seconds. That was a too long a time.
Yeah.
there was some
change
delay
of
in
center.
The
clamping.
problem in clamping, sir.
Clamping,
There
yeah.
were issues with clamping, then followed up by without any air. We were taking time to fill it up to get it without any air column. So that took time basically.
But still there was an air in
connector-
that when you connected, isn't it? Okay. You need to practice a lot. 1 minute 54 seconds is too a long time. It has to be within 30 seconds to 40 seconds. That should be your target. See, if you were to change the oxygenator faster, there would not be a
Arrest.
bradycardia and they would not have required to give CPR. So this was eventually iatrogenic complications which we made it, isn't it? Why didn't you think of doing a clamp down time and see? You could have asked some expert to come and change the oxygenator. Agreed, but then you are see, once you have cut oxygenator, you cannot do anything. If you have just clamped it and you have seen that within 30 seconds the heart rate starts dropping down, you could have just released the clamp, re-establish the circulation, okay,
Oh, it called an expert.
and then you could have asked for an expert people to come and
Definitely.
manage it,
Correct.
Okay.
isn't it? Because this was not an emergency. unlike your pump failure where the pump stops suddenly, this was not an emergency. You could have buy some time managing with this oximeter.
But saturation was
Yeah,
already dropping.
dropping
Then.
some.
You could have gone up on the flow.
You could have increased the flow, you
We
could have increased the
we
sweep
tend
gas
to
flow,
increase
so
flow.
you could have improved
Yeah.
the bed of oxygen. You have a time to do everything, and then you could have clamped the circuit.
Yeah.
So once you have cut the circuit, you can't do anything. That you understand what I'm trying to say.
Yes, sir.
So till the time you have not cut the circuit, you have still more options to do it. Unless, see, if it would have been emergency anyway, there was no other options. But till the time you could have tried everything and see what can be done best. You could have more manpower. You could have planned everything and then clamped the circuit. So the many things could have been done. And
See, here you can itself see the situation. When the ECMO was going on, there was no heart rate was fine, blood pressure was fine, though saturation was less. But once you clamped the circuit, what happened? Patient had a bradycardia, cardiac arrest. So this could have been prevented by having the team, another expert inside in the team, and doing the preparation. Everything is prepared, and then you quickly change the oxygenator. Okay.
try to minimize off ECMO time. That is what we intend to. Okay, and you need to keep on practicing till the time you change the circuit or oxygenator or pump within less than 1 minute. Okay, that should be your target. What I mean to say is, whenever you do this in your hospital, keep a ECMO circuit preserved. Don't throw it away. Clean it and keep it preserved, and keep on ask your staff to keep on practicing on that. This nobody can teach you. We can just give you some hints how to do it quickly, okay, but it's a practice only. So other than practice, nothing is going to help you. So you need to do it, and it's just a practice. So previously, when I used to do it, I used to finish in less than 30 seconds. Okay, now my team finishes in 25 seconds. Okay, and now if I do, I'll take 40 to 50 seconds, not less than that. So it's just a practice. Now because they are doing it regularly, now I am not doing, so I might take a little more time. And they are just finishing in 20-25 seconds, that's it. So that's the target you should keep, and keep on practicing in on that. Okay. Anyway, thank you. Any questions from audience or from here?
So how can we differentiate?
Sir, one question.
Yeah.
Sir, our ICD was in situ and there is no ongoing bleeding and oxygenator is like started clotting. So what will be our ACT target?
Yeah, that's the most difficult questions. And if you see the scenario, and this is probably happens actually in real lifetime, that you have an patients on ECMO. Patient develops pump clot, so you increase the target of ACT. He develops hemothorax, so you decrease the target of ACT. You develop oxygenator clot. So this is a dynamic thing which keeps on, fluctuating. Now, as the number of days increases, probably you might have to switch over from ACT to APDT as a target. That might help you to some extent. Or if you have a facility of getting an anti-10A or something, then probably this is where the role actually comes. So prolonged ECMO, definitely your monitoring targets should change over to APDT or anti-10A. They are a better guide rather than your only ACT. So that is what needs to be done. Usually what we do is we do APDT once in a day, and we do ACT 4 hourly. Morning sample, when we take APDT, we just simultaneously take the ACT sample, and both the sample we run at the same time. And then we target our ACT depending on the APDT. So suppose my APDT is say 50, okay, which is my target now, and my ACT is at that time is 140. I consider 140 as an ACT target, and I just try to maintain ACT target to 140 to 150 throughout the day. Okay, that is what I usually adjust. So we can cut down on APDT investigations also. Anti-10A usually is not easily available across India, and if at all it is available, it takes longer time to come. So usually I don't follow, but then all Western papers says that as the number of ECMO days goes more than 2 weeks, probably anti-10A and APDT is a better monitoring target as compared to your ACT. Anything you want to add?
No, sir. Absolutely fine.
Any other questions? You had some questions, yeah.
So how do we differentiate membrane edema and
Bring it to close to your mouth. Yeah.
how can we differentiate membrane edema versus oxygen?
In membrane edema, the delta pressure will not change. It won't increase. In membrane edema, there won't be a hypoxia. It will be purely a hypercapnia. Okay. So that is, treatment is very simple. Just increase the sweep gas to 15 liters for just 10 to 15 seconds. That's it. And you will see literally the water molecule coming out of the exhaust line. So one point you learn.
I mean, we could increase the sweep gas flow before changing of the oxygenator.
Yes,
That
you can
one.
increase the sweep gas and get the CO2 down
CO2.
just to buy few seconds. See, all these measures are just buying 1 second, 5 second extra, that's it.
So not to rely on the delta P, we have to calculate manually the pressures are.
Yeah, so always keep your eyes open, delta pressure calculation. So any device which gives you a calculated value, don't blindly rely on that. Look at the true values, okay.
Always see do an oxygenator clamp so that you will know how much time you have before
Yeah.
doing any procedure.
Those centers who are new, you should practice this clamp down time so that you know how much time is going to take. Once your team is tuned to change the oxygen in 30 seconds, 40 seconds, then we don't do clamp down time, to be very honest. None of my staff is going to do it. Even if I tell them to do it, they are not going to do it. Because they know that they will change in 30 seconds, 40 seconds. But that once we reach to that level, you need not have to do this clamp down time. And that's why you don't find this in the book, clamp down time. But this is what we learn practically. Those centers who are still new, they can do this and they can arrange an expert team to do that.
Yeah, change of oxygenator is like elective procedure. We have to prepare everything before clamping the.
Yeah, before you clamp, do everything whatever possible. You to see that your clamp down time remains minimum. Okay.
AMBO should have been initiated.
Yeah, if the lungs are stiff, don't rely on ventilator. Just take the patient on AMBU. Few minutes of AMBUing is not going to harm anyway.
No adrenaline as far as possible.
Yeah, avoid adrenaline. I'll not say no, but I'll say avoid adrenaline as far as possible.
Yeah, have a team ready. I mean, inform the perfusionist and others also when such things happen. Decide when it's emergency to change.
Yeah, so perfusionists will definitely be of better help in this kind of scenarios because they will able to change the oxygen much faster than this. And you could have avoided all rest of the things. Yeah, so clotting is always a problem if you stop heparin. So simple thing like increasing the RPM, increasing the flow
Yes.
could have avoided